This UCSD TV program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest programs.
Hi, everybody. I'm Dr. David Granet, and welcome to Health Matters. You probably know that people have heart attacks all the time, but almost 1,000 people a day die from cardiac arrest. That's an amazing number if you think about it. The total number of people impacted by this is actually more than die from AIDS, breast cancer, and lung cancer combined. Think about that. There's got to be better ways to help prevent these from happening, or to deal with them when they occur, and there are. And we have with us a real world's expert on this topic who's going to help get us through all this. And I'm going to get this name right, Ulrika Birgersdotter-Green. Did I do it?
Well,
close?
you were close.
Okay, I'm working at it.
It takes a Swedish tongue to say it right, but you can say Ricky and that will be
okay. Dr. Green is a professor of medicine and cardiology and director of the pacemaker and ICD services for UCSD. Welcome.
Thank you.
The numbers are astonishing when you think about it, how many people this affects. We hear more about those other diseases like lung and breast cancer and AIDS than we do about cardiac arrest. But it's sitting there as this major event that's happening all the time throughout the whole world. This is not a little deal. This is a big deal. So when we think about it, how do we make a difference in this? What happens when someone's heart stops beating? What is the event?
So it's a big question. And taking it from the start, what happens when a patient's heart stops beating? In the majority of the time, it's because it goes into a fast abnormal heart rhythm, something called ventricular fibrillation or ventricular tachycardia. And what has been shown over and over again is that getting to that patient early, quickly, is incredibly important. So appropriate CPR and having an external, one of those automated external defibrillators available also makes a difference. That is what really impacts survival for the person who is experiencing this event. So
we know this is a big deal.
We want that patient to make it, to survive, to get to the hospital, so that I have a chance to then talk to the patient about how can we make sure that this doesn't happen again to you.
Most people think of the heart as a pump, right? Because it's pumping blood all around. But something's telling those muscles to contract. There's an electrical circuit that runs through the heart. Can you tell us a little bit about that so people understand what's going on and how the heart actually functions?
The patients who can have sudden death are the ones that we know it happens and they survive and they make it to the hospital. But there are patients who are at risk for having sudden death. And I think it's really important that we are able to get to those patients and talk to those patients about their risk and how can we help them. So how do we know that a patient is at risk? And this is sometimes a difficult question when we talk to patients, but there are certain things that we do know. And this has to do with then the patient's electrical system and their risk for developing these abnormal heart rhythms. Patients who have known heart disease, patients who have had heart attacks in the past, can develop scar tissue. So part of the heart muscle is no longer really good functioning heart muscle, but it's just scar tissue that is the perfect substrate for bad abnormal heart rhythms. So we do echocardiograms. We look at something called ejection fraction to see if there is a reduction in the pumping function, if there's scar tissue there that could increase the risk.
So this is all great, but I want to make sure that our folks listening understand it. There is an electrical system of the heart. How does that work?
There's an electrical system of the heart. And normally there's very distinct tissue inside the heart that is able to conduct electrical impulses. Starts in the upper chamber of the heart works its way down this specific pathway to the lower chambers of the heart and makes the heart beat.
And that's a coordinated rhythm. So first the top chambers empty into the lower chambers, and then the lower chambers push that big load of blood out around the body.
And that coordination is happening through the electrical system, making sure that this actually takes place.
And when you say rhythm, that's what you're talking about, is that's rhythmatically working the way it's supposed to work in the order it's supposed to pump.
Exactly.
And so then for some people that goes completely awry,
So that
or
goes
they have damaged
completely
tissue
awry.
that interrupts the wiring, the electrical signals in the heart.
Yes.
Okay. Now you used the term echocardiograms. That's using ultrasound to evaluate how the heart functions.
Yes.
How does that work?
So that's basically the same idea as when you come in as a pregnant mother and you get ultrasound pictures of the baby. It's very, very similar to that. This is a transducer that you put on the chest, and you look to see the heart function, heart valves, the pumping. You get real live images of the heart's function.
So you have that, and then you have, everybody's, I think, familiar with an EKG when you put the little stickers on their chest, and you can get the electrical signals. You can actually record them. So you're looking at those electrical signals, the echocardiogram with the ultrasound, like the pregnant woman, to see whether or not the heart's working appropriately.
Correct.
Okay, and if there are things you notice that tell you it's not. If a person is feeling okay, how do they know to get those tests done?
So another really good question. Patients who have known heart disease should certainly make sure that they follow up with their cardiologist. And the cardiologist would at times check an echocardiogram to make sure that they stay on top of those things. It's a very, very common procedure. But it is something that they should be aware of.
And then, so now we have the person who's at risk, and at some point they end up with a cardiologist, and you say, this isn't a little risk, this is a big enough risk that you're really one of those people who your heart could stop functioning properly. There's a separation there that happens somehow.
So that patient comes to me referred from a cardiologist. The cardiologist say, now I am worried about you having an increased risk of dying suddenly. So I think you should go and see Dr. Green, who is an electrophysiologist, and talk more about your risk. So that patient comes in and sees me.
So you're not just a cardiologist, you're this subspecialist electrophysiologist.
Physiologist.
So that means that you're the specialist in how the electrical conduction of the heart takes place.
That's right, yes. And in addition to that, my specialty and my particular interest is sudden cardiac death and defibrillators and pacemakers, that device management of heart rhythm.
So I'm already
problems.
nervous when I come to your office because I'm thinking I could die because my heart's going to stop, right? And you've become a very important person to me because you're the person who might stop that from happening, right? I mean, that's a very big moment when they come into your office. It's a big visit for them, I would think.
I hope so, but I hope that they're not too nervous about it. I think this is where you have a good conversation with your patient and make them comfortable and talk about the risks and the benefits and what we can do, should or shouldn't do.
Okay, so now you've decided someone's at high enough risk that we need to do something. What are the choices of what you would do for someone who's at high risk?
Depends a little bit on the patient's background, but your typical patient comes with an echocardiogram looking, say your ejection fraction is low, where we see scar tissue there, we think that you have an increased risk. Or this may not be due to a blockage, it may be due to other reasons, but the heart muscle is big and dilated and not working well. So with that in mind, we should then talk about what have we learned over the years. And what we have learned is that it is very important for those patients to get good medical management. That is the kind of foundation for everything we do. Beyond the medical management, there has been no study showing that there is a magic pill that we can give that makes sudden death not happen. Doesn't exist.
Okay, good to know.
What the clinical trials have shown is that in patients who got the defibrillator, that those patients did have a significantly increased survival.
Okay, so now we have to say what a defibrillator is.
So now we're going to talk about the defibrillator, because
what is
that
it?
is. You remember how we talked about that automated external defibrillator that saves so many patients' lives?
That's the paddles that you put on the chest and go, and
exactly.
What does that do?
That changes that bad, abnormal, ugly ventricular fibrillation to a normal rhythm.
So the electrical system going through the heart is going blah, 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 right? And now you zap it with more electricity? Is that the basic idea?
That's the basic idea.
And it's like rebooting a computer?
Yes.
And it restarts, and you hope, or you expect that it will go back to a normal rhythmic pumping?
You expect that it's going to go back. It works extremely well.
Okay.
So the same concept is now taken to an implanted defibrillator. So now the patient has that same function, but not depending on something that is external, but it's implanted in the patient. So the patient has this defibrillator on backup.
Because if you're in a restaurant or you're someplace, they may not have a defibrillator.
Right.
But if you have it implanted, you have it everywhere you go.
That's exactly right. Yeah.
So now people are going to think of something else that sounds a little bit like this, and that's a pacemaker. You implant it, and it tells your heart how to beat. This is different.
It's different and yet similar. So the procedure of putting these two devices in are very similar. A pacemaker is there to make sure that a patient's heart rate doesn't go too slow. A defibrillator is there to make sure that a patient's heart rate doesn't go too fast into these abnormal heart rhythms. But the defibrillator, in fact, has all the capabilities of a pacemaker. So the defibrillator is kind of the ultimate device, if you so will, because it covers the spectrum.
Yeah, and you said it does what those paddles do. I think of a big machine, big paddles, and somebody flips a switch and all that. You have some samples to show us of the sizes of these things that make it implantable. So
this is what a basic defibrillator looks like. And they come in slightly different models, slightly different shapes, slightly different thicknesses, but this is basically what it looks like. And we can compare that then to a pacemaker. So you can see that the defibrillator is a little bit bigger still than a pacemaker, a little bit thicker certainly. But over the years, the technology has advanced incredibly on the defibrillator.
That's amazing. That duplicates what you can get out of those big paddles.
Yes. Once upon a time, this was the size of my hand, was implanted in the abdomen and required open heart surgery, and that's less than 20 years ago.
Wow. Where does this get implanted now?
So now, if you're right-handed, it goes on the left side and in fact sits right here, and I make an incision under the skin, and I make a pocket for this device under the skin and under the fat tissue. So it shouldn't be big, shouldn't be bulky, it should look nice and good. There's a big blood vessel that runs right under the collarbone, and the wires, usually 1, 2, or sometimes 3 wires, depending on what type of defibrillator we choose, they go through this big blood vessel, then that is a straight shot into the right side of the heart. So one wire will always go in the right lower chamber of the heart. That's the big, most important one. Some patients need an additional wire in the right upper chamber. And some patients, depending on their electrical system and some other indications, may in fact benefit from a third wire that will wrap around and reach over to the left side of the heart and have the capabilities of pacing right and left.
And as an electrophysiologist, before you walk into that setting, you've tested the patient with electrophysiologic testing so that you know which wires and how many they need?
You in fact don't even need electrophysiologic testing. This is where a good old-fashioned EKG is really helpful. So we get the EKG and we see that this patient has, in addition to this low ejection fraction and the risk of sudden cardiac death, also some distinct electrical abnormalities making the heart beat out of sync. So I look at the EKG and I say, you know, this patient actually also has a problem with the right and the left side of the heart talking to each other. So we can synchronize that heartbeat by now pacing right and left. It's a very effective treatment option, in fact, for some patients with a low ejection fraction and heart failure symptoms.
And although these have been in evolution, some 600,000 have been implanted already?
Yes.
That's a lot of people.
Thousands and thousands.
Yes. And I assume that they have fired and triggered and prevented cardiac death in equally thousands of people.
I have had many patients over the years where we have put these in as primary prevention, so they have not had sudden death. And we tell them, you're going to get this device. You may never need it. It may be there as a backup for the rest of your life, but you may need it when you walk out of my office. And in fact, that happens in some patients. In many patients, they will have a shock from the defibrillator. And we look at that and we say, this is where you died. And this is where you recovered.
Incredible. So there's a battery in there?
There's a battery in there.
Pretty strong battery?
It's a good battery.
Does it have to be replaced?
Yes, it will last on an average about 8 years. When we replace the battery, we actually replace the whole device because battery takes up a lot of space.
Understood. And so when someone has when it actually does work, they'll know it, right? Obviously, they fall down or they get the shock and they feel it. Are they expected to come right into you as soon as that happens?
So the majority of patients will feel the shock, and I will always tell them that most likely this is going to feel like a good jolt to the chest, even a horse kick in the chest sometimes.
Okay.
So it's not a subtle finding from a patient standpoint, but there are patients who can't tell that they have a shock. So there's a little bit of a spectrum of patients there also. If a patient has a shock, what we tell them is that they don't necessarily immediately need to rush to the emergency room. That's why you have the defibrillator.
Yes.
Almost all our patients have what we call home monitoring or remote monitoring. So they have a little thing on the bedside that checks this device every day, or every night, in fact, at 2 o'clock in the morning or so. It uses wireless transmission, finds the patient in his or her bed, does a full interrogation of the device.
Have you fired today?
Exactly. Everything gets checked. If everything looks normal, it goes to a filter, stops in the filter, we're happy. If anything falls out of normal, obviously a shock would fall out of normal, it will go through the filter to my screen, and I will have an alert, and I can get a full check of the device right then and there.
I'm picturing you at 2 in the morning up looking at your screen.
There will be somebody always on call to see these things.
To see,
yes.
wow.
Yes.
So that's a real sense of security for the patient to have that.
Yeah.
That's incredible.
So what we tell them is if you have a shock, go home, push a button, make a transmission, we'll take a look at it.
Wow. What a great infrastructure for the patient.
Yes.
So let's walk through for a couple of minutes of what the patient goes through when these are implanted. This is done in a hospital setting?
It's done in a hospital setting. We do them at our Sulpicio Cardiovascular Center, which is a great facility for these type of procedures. Dedicated staff, dedicated procedure rooms. This is what we do all day long.
And it's brand new here at UCSD, an incredible facility. So they come into this place that does hearts and cardiovascular work. And are they expected to stay overnight? So
we have them stay overnight. So it's a 24-hour stay in the hospital, basically. The procedure takes an hour and a half. But there's anesthesia involved. It's a good thing to spend the night.
And the procedure is basically making the pocket as well as placing the wires?
Exactly.
How do you place the wires?
So that's when we go through that blood vessel into the heart. We use fluoroscopy, which is kind of like a very mild version of X-rays. That's what guides us into the right location of the leads.
So using that, you can make sure that the pocket's made and the wire's in the right place. You're actually seeing the heartbeat, and you're seeing where the wires are placed. That's pretty cool. To be able to go into someone's heart and do that. You must love what you do.
I do love what I do.
I can tell. Yes. It's very obvious. So do these fail?
Very, very, very rarely. No technology is perfect. Having the actual device fail, I can't tell you if I ever remember having that happen. The more vulnerable portion of the system would be the wires that we put in there. Because those wires have to work very, very, very hard. They sit in the bloodstream. They work with you when you move, when you do things. I mean, they are just, constantly really under pressure, if you so will, to work well.
Right.
So that could potentially be a problem, and we do see that at times, and we're very, very aware of the fact that can happen.
And is there anybody who's not a good candidate?
each patient, obviously, I think you really need to individualize this. You need to have a discussion with the patient about the pros and cons. I would never say that to a patient, not a good candidate, shouldn't happen. I think a patient that comes to me with the question, should he or she have it, deserves the discussion of what is good and what is bad.
These equipment that you're showing us has evolved over time. Where do you see it going? What's the next generation, and then maybe the science fiction of where we're going to be in 50 years?
I think looking back at the last 10 years of technology, the biggest impact for patients and for myself, it has in fact not been so much in the device as it has been in this remote monitoring, because that makes such a difference.
It's amazing.
And it really, and that has evolved too, that of all the things that I would pick, I think that makes a difference. Going from here, what will happen next? They could be made a little bit smaller. That's certainly possible. But as I mentioned, the most vulnerable portion is really the leads. So if we can get to systems that could potentially do all of this and not have implanted leads, I think that would make a difference. That may not be for all patients, because the leads do many good things and would not be easily replaceable. But there are systems available now and emerging more and more that will have leads put in, not in the bloodstream, but rather subcutaneously, meaning under the skin and under the fat tissue. So different models, the subcutaneous ICD, and I think we're going to see more technology evolving along those lines.
And I think, like everything else in medicine, this is great technology. I hear the evolution, but it seems to me that the trick is making sure the patient who needs it gets to you. And identifying the person at risk is the first step. Are we going to get better at that?
I hope so, because we're not doing a good enough job now. And there's a lot of talk about patients getting defibrillators, and I think it's a little unfortunate that there is discussions about defibrillators not working, leads not working, where the biggest discussion really is that there are so many patients out there that meet indications for defibrillators. They should at least have the opportunity to discuss this with their doctor.
Yeah, I mean, this is obviously something that's saving lives,
yes.
And that works, and it works really well. So if I'm at home right now watching this show, how do I know that I'm not at risk for this? Because it's sudden cardiac death. You don't always get warnings. Is this where everybody over 50 should be getting checked? Is it, everybody over 50 should be getting an implantable one to prevent the problem? Is it, if you're 80, should you be thinking about this? Who and how?
There's obviously no, if there was a perfect way to risk stratify patients, we would all be very happy. So that isn't there. There is not something that I could say, if we do this one test or we check this, I can tell you exactly what your risk is. We have to start with the boring and mundane type of things, but I have to say that there are things that you and I can do to minimize our risk, and that's living a healthy lifestyle. So exercising, not smoking, eating right, checking your cholesterol, these things are very, very important and will overall impact your cardiac risk in general. So we have to talk about good old-fashioned primary prevention. That is important.
It's funny, isn't it, that we still come back to that,
yes.
right? I mean, these
yes.
incredible
yes.
technologies with that's going to talk to a box
yes.
at your house
yes.
and alert
yeah.
your doctor, isn't as good as never having the problem in the first place. And so a cardiologist
yes.
still is going to tell us to
yes.
eat well, live
yes.
a healthy lifestyle.
Not going to get away from that.
So that's still the primary.
Yes.
In the time that we have left, I'm just wondering if you could create the world according to you. What would you like to see happen? We've talked about the prevention aspects of this, but in terms of getting the patients and then what you can do, if you could, snap your fingers or get funding to develop the research that you want to do, what would you want to see happen?
I would, first of all, really like to see more happen when it comes to what we can do early on. So the patients, if they do have sudden death out on the soccer field or in the shopping mall, that we have all those processes in place. The first thing is having those patients increase their chance of survival. So I'm big for automated external defibrillators, CPR training. Gotta do this.
It's life-saving.
It's life-saving.
I just saw, there was an article in the local paper where I live that one of the kids I used to coach on my soccer team, who's now 17, had just taken a CPR class and a week later saved someone's life in a shopping center where they live.
Yes.
Just, I mean, saved a life because he knew CPR. So that's important for everybody to know.
That is important for everybody.
And then, so we want to get that out in the hands of the people who need it so that care can get where it has to get. And then we need the people who are at risk to get to you.
Yes.
Can you take care of everybody?
I would love to.
I think you're pretty busy. So, well, thank you so much for coming and talking to us about this incredible technology and the advances in what you're doing and the life-saving technology and life-saving work you do for all the people here in San Diego and around the world that you touch. Thank you so much for all those efforts.
Thank you for having me.
Well, there it is again. Knowledge is power. Every time we're here on Health Matters, that same phrase comes up. Taking care of yourself to prevent a cardiac problem, identifying it if it occurs, getting to the right person, all of it matters. And the more educated you are, the healthier you'll be. I'm Dr. David Granet. We look forward to seeing you again next time right here on Health Matters.